Good evening, everyone. Welcome to NEET PG, to Unacademy, where you can crack all NEET PG exams with us, with our top educators, quality content, and great learning experience. So, guys, let's crack NEET PG. A little about me. I have done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. So, guys, let's crack NEET PG. My topic for today is neuromuscular monitoring. In my previous 2 classes, I have dealt with uh, the 2 neuromuscular blocking drugs, that is your succinylcholine and non-depolarizing muscle relaxants. Here I will be dealing with the neuromuscular monitoring aspect of muscle relaxation. So guys, a little about Unacademy now, where you can crack NEET PG. It is because it is one of India's largest learning platform which helps you to crack the NEET PG. You get plus subscriptions and access unlimited live and recorded courses from India's best educators. So guys, hurry, get your subscription. So now, what will you get out of Unacademy? You have your daily life classes. So basically, when you're sitting in a coaching institute, you cannot clear your doubts one-on-one. It's a big class. It's difficult to get your instructor to engage with you to clear your doubts then and there. Here on Unacademy, Unacademy, on the Unacademy platform, you can chat with your educator, engage in discussions, clear your doubts, and all this while the class is going on. So there are structured courses. These courses are all structured. They in line with your exam syllabus after thorough research, and they help you best prepare for it. There are also live tests and quizzes which evaluate your preparation, and you can get a detailed analysis on your performance. Also, there's unlimited access. One subscription can get you access to all our live and recorded courses, where you can watch from the comfort of your device and the comfort of the place wherever you are. So it is just one subscription. You are sitting at home, you are saving your travel time that you would spend going to a coaching class. So you are saving that much of energy, and you're getting a structured course. You're getting prepped with the quizzes, polls, tests, all from your own device and the comfort of your place. These are some of our top educators: Dr. Nikita Nanwani, Dr. Mohammad Azam, Dr. Divish Mishra, Dr. Preeti Sharma. We have 19 courses, as you can see, that are offered to you all, and there are top educators teaching you all in each of these courses. These are some of the ongoing courses on our platform. That is the neurophysiology, GI surgery, cardiovascular, thoracic surgery, course on the larynx, respiratory system, pathology. Now coming to the most important part, the subscription part. So as you can see, there are five types of subscriptions here: the 1, 3, 6, 12, and the 24. I would highly recommend that you all go for the 12 and the 24 months. I did the same. Of course, when I was preparing, it was in NEET PG, but the preparation time covering 19 subjects in 6 months, 3 months, 1 month, come on guys, it is not impossible, but it is difficult. So, and you cannot cover them thoroughly. The understanding will not be there. But with your 12-month course, it's a structured course over 12 months. You have your tests, recorded classes. You can always come back at your own time. There's no hurry. You can prepare in a structured manner, and it is economical. How is it economical? Because it is one subscription. So after 6 months, you will have to subscribe again. After 3 months, you will have to pay again, subscribe again if you take those subscriptions. But a 12-month subscription, it's there for 12 months. You don't have to pay in those 12 months, and you have access to the live classes, recorded classes, tests, everything during those 12 months. Same goes with your 24-month subscription. So guys, subscribe 12 and 24 months are the ideal ones, and use my code as you can see at the bottom of the screen, SASHA in red, and you can avail a 10% discount. So guys, don't waste time, subscribe, start your preparations. Again, the 24-month subscription, use my code at the bottom of the screen in red, SASHA. You will get your 10% discount. Guys, don't waste time, like I said. Let's prepare. So now let's move on with the topic, that is your neuromuscular monitoring. So why is this monitoring required? So basically, we dealt with the two types of neuromuscular drugs, that is your depolarizing and non-depolarizing agents. So this is your succinylcholine, and this is your basically your atracurium, becuronium, rocuronium. These drugs I dealt in detail with them in the previous class. Basically, these drugs cause muscle relaxation. Now the need for muscle relaxation, like I said, for tracheal intubation prior to a surgery, or if the airway is compromised, or for us basically for surgical field optimization, so that the surgical field is relaxed and the surgeon can operate in a stress-free manner. You need muscle relaxation. Now the recovery, when the patient is recovering from the muscle relaxation, when do we know that we can take out the tracheal tube? Yeah, when do we know we can extubate the patient? That is one criteria to know for safe extubation, so that there is no residual paralysis. When you prevent residual paralysis, you prevent the risk of aspiration and pulmonary complications. So you have to extubate the patient when there is no residual paralysis, and clinical signs are not enough. We generally follow clinical signs most commonly, but clinical signs are not enough because some degree of paralysis will still remain. So clinical signs are not enough. It has to encompass clinical signs, qualitative monitoring, I'll come to this later, and quantitative monitoring. Yeah, so I will come to these. So these all three have to be encompassed to know that there is adequate reversal of muscle relaxation before the patient is extubated. Also, not only for extubation, during a surgery, to know the depth of blockade, so that the patient depth means the patient, certain surgeries you require the patient to be completely the depth of anesthesia has to be complete. These are especially the neurosurgery, your neurosurgery, ophthal surgeries, because these are very delicate surgeries. You cannot have your patient moving, right? You cannot have your patient moving. So you need to know that the depth of blockade is complete. So you can monitor during the surgery, ensuring complete depth. So now what if there is residual post-operative neuromuscular blockade, like I said prior to extubation? So what happens? There is decreased chemoreceptor sensitivity to hypoxia. Okay, this is basically by the chemoreceptors in the carotid body, right? The receptors for hypercapnia are in your brainstem, but these receptors, hypoxia receptors, are in the carotid body. So these chemoreceptors, that sensitivity is decreased when there is residual paralysis. Hence, the activation of these receptors, which will counteract hypoxia, is not happening. There is impairment of the esophageal and pharyngeal muscles, which can lead to aspiration. Yeah. There's impaired ability to maintain an open upper way because these pharyngeal and esophageal muscles can collapse. And of course, pulmonary complications secondary to aspiration. So we need to avoid all these. To prevent all this, we need to see that there is no residual neuromuscular blockade. For that, we need to monitor. We have monitors which we need to monitor the depth of blockade prior to extubation. So the objectives of neuromuscular monitoring are to determine the onset of, so before the surgery starts, to determine the onset of neuromuscular blockade so that the surgeon can start surgery. The patient is completely paralyzed and has no sensation when the surgery is starting. To determine the level of muscle relaxation during surgery, like I said, in your neurosurgeries and your ophthal surgeries, right? Neuro and ophthal surgeries, and assessing the patient recovery from blockade to minimize residual paralysis. This is important. Who should be monitored? Basically, high-risk patients are monitored, like patients with severe renal disease, severe liver disease, neuromuscular disorders like myasthenia gravis, because like I discussed, myopathies, upper motor because the muscle relaxants have varied actions on these. Myasthenia gravis potentiates neuromuscular blockade. So even though the duration of action of the neuromuscular blocking drug is over, they can be still blockade, right? So even though normal duration of action is over, there might be some clinical signs of recovery, but because myasthenia is a syndrome which precipitates this neuromuscular blocking drugs, there can be residual blockade of the receptors. So to assess this, we need to monitor patients with severe pulmonary disease, marked obesity. Again, the respiratory drive is altered in these patients, so it is difficult to assess whether these patients have completely recovered. During continuous infusions of neuromuscular blocking drugs or long-acting neuromuscular blocking drugs, because if there is any residual drug remaining, long surgeries, again because a lot of neuromuscular blocking drug will be used, and surgeries require elimination of sudden movement, like I said, your ophthal and neurosurgeries, and surgeries requiring, again, where you require profound blockade, basically no sudden movements. So there are two ways of stimulating a nerve. Basically, your electrical is the most commonly used in clinical practice. I'm so sorry. Your magnetic is less painful. The electrical stimulus is really painful, but these patients are anesthetized. So it's okay in these anesthetized patients because we generally deliver supramaximal stimulus, not a normal stimulus which stimulates a nerve. It's a supramaximal stimulus. It is a stimulus 25% more than a normal stimulus. So you can imagine how painful it's going to be, right? So problem with electrical stimulus is it is painful, but in an anesthetized patient, the patient cannot feel it because the patient is under anesthesia, right? So that's generally okay. But in awake patients, it's very painful. And the magnetic, it is less painful. It does not require physical contact with the body, unlike your electrical. But the problem with this is the equipment is bulky, okay, and it is difficult to achieve a supramaximal stimulus. Hence, it is not commonly used. But the advantages are it is less painful and no physical contact. Now, principles of nerve stimulation. Each muscle fiber, when stimulated, follows a all or none pattern. That is, it will respond. But the response of a whole muscle depends on the number of muscle fibers activated. A particular number of muscle fibers have to be activated for response. Now, when the muscle is when the neuromuscular relaxant is given, after the relaxant is given, the response of the muscle decreases in parallel with the number of fibers blocked. So, paralysis depends on the number of fibers blocked by the muscle relaxant. So, the response will decrease in parallel with that. This reduction in response during constant stimulation reflects the degree of neuromuscular blockage. So, this as the muscle relaxant is binding to the receptors, the response, because there is no depolarization, the muscle contraction response decreases in parallel with the number of fibers that are blocked by the drug. This reduction in response that is happening, even though there is constant stimulation, reflects the degree of neuromuscular blockade. Hence, for this reason, a supramaximal stimulus has to be applied. This is important. So, a supramaximal stimulus is given, okay, because you have to, the constant reduction in response has to be noted, and the muscle is blocked. The receptors are blocked. There is no depolarization occurring. So, a supramaximal stimulus has to be given to see the effect, whether it is because depending on the degree of blockade, whether it is completely blocked, there will be no response. So partially blocked, you will get a partial response, okay, on the monitor, on the neuromuscular monitor. Hence, a supramaximal stimulus is given. So, essential features of peripheral nerve stimulation. The shape of the stimulus should be monophasic and rectangular, a square face pattern. 0.2 to 0.3 millisecond duration so that it falls within the refractory period of the motor unit. Constant current and variable voltage. The current has to be constant as it is safer, and a variable voltage should be battery powered. Again, for safety purposes, it should be battery powered. Better not to be connected to electric plug points. And there should be a digital display of the current in the form of however the response is. So a digital basically like this, there will be a digital display of current on the monitor. A digital, whatever voltage and current is delivered, there will be a digital display. Audible, there should be an audible signal whenever the stimulus is delivered, so that the observer is aware that the stimulus has been delivered. An audible alarm if the electrode is poorly in contact with the concerned nerve and muscle. And multiple patterns of stimulation should be available on the nerve stimulator, that is your single twitch, train of 4, double burst, and post-tetanic out. Now, current intensity, the nerve stimulator generally, so I'll just tell you briefly. Firstly, it can be neuromuscular monitoring, can be classified in clinical features, based on clinical features. Like I said previously, qualitative, that is your peripheral nerve stimulator, what I am talking about right now. And lastly, quantitative. Basically, quantitative is however the nerve is being, whatever stimulus is given to the nerve, it is represented in a graphic form. These are your electromyography, acceleomyography, and muscle myography. Okay, so right now I'm talking about a peripheral nerve stimulator. Okay? These are qualities of these both, as these both are mechanical things. Clinical features I'll tell you briefly at the end. So the current used, it is milliampere, delivered by a nerve stimulator. It should be between 0 and not more than 80 milliampere, as that is more than, okay. The intensity reaching the nerve is determined by the voltage generated by the stimulator. So the intensity of current is determined by the voltage generated by the stimulator, and the resistance of the electrode, skin, and underlying tissue. So the response depends on the voltage delivered by the stimulator, and the resistance that is caused because of the impedance of the electrodes, because electrodes are placed, the skin, and underlying tissue. So whenever there's a decrease in temperature, there's an increase in the tissue resistance, there's increase in the impedance, which can cause in the reduction in the current delivered. Okay, this will alter the response. So what is threshold current? It is the lowest current required to depolarize the most sensitive fibers. Your supramaximal current is what we use for neuromuscular monitoring, that is 25% higher intensity than the threshold current to depolarize all fibers in a particular nerve bundle. It is 2 to 3 times higher than the threshold current. The stimulus frequency, the rate at which each impulse is repeated in cycles per second. Now the electrodes, there are two types of electrodes, your surface electrodes and your needle electrodes, right? Your surface electrodes are pre-gel silver chloride surface electrodes for transmission of impulses to the nerve through the skin. The transcutaneous impedance, the resistance can be reduced by rubbing them, and the conducting area, the area of the electrode should be small, 7 to 11 millimeter. So now your needle electrodes, they are subcutaneous needles that deliver impulses directly near the nerve, and hence they require less current, but we most commonly use surface electrode. Needle electrodes are mostly used during neurosurgery when they are doing they do not require muscle relaxation and they require direct stimulation, like the Broca's area. If there are any tumors or any epileptic foci, like example near the Broca's area and all, if they need to test the response of the patient during the surgery, these electrodes will be placed close to this Broca area and all that. So that time needle electrodes are used. That time the patient is not paralyzed, but he is anesthetized as to there is no recall. So he is there is no recall and analgesia is taken care of. Now polarity, the stimulator produces a direct current, so basically by one positive and one negative electrode. This should be indicated on the nerve stimulator. The positive and negative polarity should be indicated. Maximal effect is achieved when the negative electrode is placed directly over the most superficial part of the nerve being stimulated. Positive electrode should be placed along the course of the nerve and proximal to the negative electrode to avoid direct muscle stimulation. So the negative electrode is placed directly over the most superficial part of the nerve, and the positive electrode is placed about 1 to 2 centimeter above the negative electrode to avoid direct muscle stimulation. So the various sites used in your ulnar nerve is the most common site for neuromuscular monitoring. Okay, so the negative electrode, which is your black electrode, is placed on the wrist in line with the smallest, with your little finger, the smallest digit, 1 to 2 centimeter below the skin crease, right? And the positive red electrode is placed 2 to 3 centimeter proximal to the negative electrode. Your response is your adductor pollicis muscle, thumb adduction. Your facial nerve, the negative black electrode is placed by the ear, and the positive electrode is placed 2 centimeter from the eye, that is inferior and lateral to the eye. This is your course of your facial nerve. So one near the earlobe and the other inferior and lateral to that eye, corresponding to that side of the ear. The response is your orbicularis oculi muscle. There will be eyelid twitching. Your posterior tibial nerve, the electrode, the negative electrode, your black electrode, is placed over the inferolateral aspect of the medial. So you palpate the posterior tibial pulse, behind the medial malleolus, and the positive electrode is placed, and you place the electrode there. Yeah, basically it is palpated over the posterior. You palpate the posterior tibial pulse and place the electrode there. Posterior tibial is felt behind your medial malleolus, and your proximal positive electrode is basically 2 to 3 centimeters proximal to the negative electrode. Response is plantar flexion of your big toe, flexor hallucis brevis muscle. So plantar flexion of your big toe. Now coming to the patterns of stimulation by the nerve stimulator, right? How do we monitor these? So these are, so you have your single twitch, you have the single twitch, sorry, you have your single twitch, train of 4, tonic stimulation, post tetanic count, and double burst stimulation. I'll be coming to each of them, how they look. Yeah. So your single twitch stimulation, It is a single supramaximal stimulus that is applied to the nerve at frequencies from 1 Hertz every 1 second or zero point 0.1 Hertz every 10 seconds. You all need to know this. The height of the response depends on the number of unblocked junctions. Okay. The pre-relaxant control is noted, so you need to before you give the muscle relaxant, a controlled response needs to be noted and compared with subsequent responses, that is after the muscle relaxant. Responses will be depressed only when the neuromuscular blocker occupies 75% of the receptors, then only you will see a response. So the response depends on the number of unblocked junctions and a pre-relaxant control is needed. It is used to assess excuse me, it is used to assess the potency of drugs, right? It is used to assess the potency of drugs. It is useful before induction to determine the level at which supramaximal stimulus is obtained. So before induction, as a control, it can be used to determine a level at which supramaximal stimulus can be obtained. It is useful to determine the onset of neuromuscular blockade depending on what the response is. So the response, now basically the response in both depolarizing and non-depolarizing blocks, there is progressive decrease in twitch height. As you can see, there, that is your stimulus over there, 0.121 Hertz. Okay, so this is after, with your non-depolarizing blocker, there is a progressive decrease in twitch height. Okay, your depolarizing blocker also, there is a progressive decrease in twitch height. There is no difference between depolarizing and non-depolarizing. Hence, you cannot differentiate in this. In the other types of stimulation, you can differentiate, but in this, you cannot differentiate between depolarizing and non-depolarizing. Now, major limit is, one is you cannot differentiate, and then you need to measure a control twitch before you can, before the neuromuscular blocker is given, that is pre-relaxant controlled response is necessary. Now your train of four stimulation. 4 supramaximal stimuli are given every 0.5 second, that is 2 Hertz stimuli are given every 0.5 seconds, 4 in number. A fade will be noticed in response provides the basis for evaluation. So 4 stimuli, 0.5 second, 2 Hertz each, and a fade in response is noted. The ratio of the height of the fourth response, so it will be something like this. Okay, this will be the fade. So the ratio in the height of the fourth response to the first response is your TOF ratio. Okay, in non-depolarizing blocks, T4 by T1, that is your fourth response to your first response, is inversely proportional to the degree of blockade. That is, if your T4 by T1 is high, okay, 0.9, that is the highest actually. If it is 0.9, the degree of block is very less, patient can be extubated. So 0.9 is basically the end point for extubation, where there will definitely, studies have shown, there will definitely be no residual paralysis. So if your T4 by T1 is 0.1, then your degree of block is quite high. Okay, so the T4 by T1 ratio is inversely proportional to the degree of block. In depolarizing the block, there will be no fade in TOF, because there is equal depression in twitch height. There is no, this fade pattern, this downward pattern is not seen with depolarizing blockers. Okay, fade in depolarizing blockers signifies development of phase 2 block. So basically the mechanism of action for fade is because the muscle relaxants, that is your non-depolarizing muscle relaxants, also have action on the presynaptic, that is on the nerve terminal, the acetylcholine receptors. Whereas your depolarizing succinylcholine does not have any action on these uh, presynaptic acetylcholine receptors, which are located on the nerve. So fade is produced because of binding of the drug to the presynaptic receptors. But in phase 2 block develops because in higher doses, when you give the second dose, succinylcholine will go and bind to these presynaptic receptors. So you get fade in a depolarizing block only in a phase 2 section of the block. So this is your train of force stimulation, where 2 hertz stimulation are given, 0.5 seconds, 5 seconds apart. 4 stimulus are given in a non-depolarizing blockade. As you can see, there will be a fade. This is during recovery. There will be a fade. However, in a depolarizing, here the non-depolarizing blockade is given. So you will see this is as it is acting, as the receptors are occupied, you will see a fade in the response of blockade. So I'm sorry, only 4 have stimuli. And in depolarizing blockade, it is all uniform. There is no fade same. This is as it is recovering. This is the fade. So basically your TOF ratios, when there is only, it is inversely proportional to your recovery. So when a TOF ratio of 4 is present, 0.4 basically, some amount of recovery is present. So this is your, basically this is where the deep relaxant is given, and this is your recovery. So here there is even though 4 stimuli are given, you can see only one. Basically it's faded off, but here you can see all 4 stimuli, right? And here 2, this is as it is recovering. One will be good stimulus because some recovery, one will be a little less. The fade is still present here. The fade is still present. Fade is present but recovering, here completely recovered. Whereas in with depolarizing blockade, there is no fade. This also fade can be seen in a phase 2 depolarizing blockade. Now your tetanic stimulation. Your tetanic stimulation is a 50 hertz single stimulation given for 5 seconds. So a 50 hertz stimulation that is given for 5 seconds. So during a tetanic stimulation, there is progressive depletion of acetylcholine output, right? There is decrease of acetylcholine output, but this is balanced by the increased synthesis and transfer of transmitter from the increased synthesis and transfer of the acetylcholine from the mobilization stores, basically in the vesicles. So the decreased depletion after a tetanic stimuli is counteracted by this. Now a non-depolarizing muscle relaxant like your vecuronium reduces the margin of safety, because so it basically reduces the number of free receptors, and also it impairs the mobilization of acetylcholine both ways, right? It has a presynaptic as well as postsynaptic action, and hence it contributes to the fade in response to tetanic and TOF stimulation. So basically because the drug is bound to the receptor, so after tetanic stimulation there will be a fade of your response, because even though there is some acetylcholine because of increased synthesis and transfer from the mobilization store, but the receptors are blocked, so a gradual decrease in the response will be seen. So during normal neuromuscular transmission and pure depolarizing block, the response is sustained, right? See, so during a depolarizing block, the response is like over here, the response is sustained. This is your control during a tetanic stimulation. There is no fade. Again, no fade means tetanic stimulation also has a presynaptic mechanism. It's produced because of binding to the presynaptic. That means that number of receptors have to be bound. Okay, but during non-depolarizing block and phase 2 block, fade can be seen. So during non-depolarizing block, a tetanic stimulation is usually followed by a post-tetanic facilitation. So basically, after tetanic stimulation, there will be a small facilitation, a post-tetanic facilitation. This is because the mobilization and synthesis of acetylcholine still continues even after the stimulus is discontinued. There is some mobilization and synthesis of acetylcholine occurring and some binding occurring, but this usually disappears within 60 seconds. This is known as your post-tetanic facilitation. Okay. So fate depends on the degree of block, frequency, length, and how often the stimulus is applied. This is in all modes of the stimulation. The fade will depend on the degree of block, whether it is deep. I'll be coming to that. Deep, moderate, or less severe block. The frequency of stimulation, the duration of stimulation, and how often it is applied. So the disadvantages with tetanic is it is very painful. Okay, and the same results can be obtained with TOF. It's giving similar results to TOF. So basically, it's not used because TOF is less painful, and also visually or tactile predictability is very less here. So what you see, even though you can see visually, it does not mean that even though you see a response of 3 twitches, it does not mean that recovery has occurred. It does not mean that it will correspond to adequate uh, reversal of neuromuscular blockade, and there won't be any residual paralysis. Okay, so it is not visually or tactically, it is very unpredictable. It cannot be used. And since the same results can be obtained with TOF, it is better to use TOF because TOF is less painful than tetanic stimulation. Tetanic stimulation is generally not used alone. It is generally used along with post-tetanic count, which I am coming to next. So as you can see, the non-depolarizing block, there will be a fade in response. Now your post-tetanic count stimulation, what I just mentioned just now. So like I said, there will be mobilization and synthesis of acetylcholine is continued even after the tetanic stimulation is stopped, which leads to your post-tetanic facilitation. This is the count of that stimulation. So it is basically used to assess the degree of neuromuscular blockade when there is no reaction, okay, to a single twitch or TOF. So this can be used to assess the degree of when it is a very deep block. Okay, there will be no response to, there is not a single reaction to single twitch or TOF during these neurosurgery procedures when you need complete, you don't want the patient to move at all during ophthalmic surgeries when you need to assess the blockade. This can be used because deep blocks can, for TOF and single twitch, there will be no reaction, so you cannot make out whether the patient was a deep block or a moderate block. It's a little difficult, but with this post-tetanic count stimulation you can make out. So the number of post-tetanic twitch correlates inversely with the time for spontaneous recovery, right? So the more number of twitches, lesser time for spontaneous recovery. Lesser number of twitches, more time for spontaneous recovery. So how is a post-tetanic count stimulation done? So initially a tetanic stimulation of 50 Hertz is given for 5 seconds. And the post-tetanic response is observed when a single twitch stimulation at 1 Hertz is given 3 seconds after the end of a tetanic stimulation. So first, a tetanic stimulation of 50 Hertz is given for 5 seconds. This is followed by a stimulation of 1 Hertz, a single twitch stimulation of at 1 Hertz for 3 seconds. And after that, you observe the post-tetanic responses observed. So it is, like I said, used during surgery when sudden movement must be eliminated, like during your ophthalmic surgeries. and return of first response to TOF is related to your PTC, your post-tetanic count. I'll explain to you in the diagram. So as you can see here, in A, it is an intense block. There is no response to PTC or TOF, right? So this is B and C are deep blocks. Okay, that is so here your TOF is given one. This is your TOF. As you can see, there is no recovery of TOF here in a deep block. You cannot see any TOF. Now your tetanic stimulus is given and your single twitch stimulation is given here, and these are your post-tetanic stimulation. So in a deep block, you can see one. There is no TOF, but there is one PTC. This is a deep block. Moderate. This is a moderate block. Where you can see there is no TOF again, but 3 PTC, post-tetanic counts are present. This is your surgical block from which the patient can starts basically your TOF. These are deep, very intense blocks where your TOF, you cannot see your TOF as well as your single twitch, so you cannot assess the depth of block without PTC. Here, when the PTC corresponds to a count of A, your TOF starts appearing. You can see one response to TOF, right? Now your double burst stimulation. Double burst stimulation consists of two train of 3 impulses at 50 Hz tetanic stimulation separated by 750 milliseconds. So 2 impulses, 2 train of 3 impulses which are separated by, these are 50 Hz and separated by 750 milliseconds. The duration of each impulse is 0.2 millisecond. Now DBS, the advantage of DBS is it allows manual detection of any residual block. So this is the only stimulation which allows a manual detection of a block. Okay. So it allows tactile evaluation of the fade and is superior to TOF in this aspect, in this tactile evaluation. But however, the absence of fade, that is if there is no fade by tactile evaluation, does not mean that, does not exclude residual neuromuscular blockade. So basically fade should not be present. Presence of fade indicates that there is neuromuscular blockade, right? So fade needs to recover. That is, you need to have all responses, right? Your fade, all your responses need to be, it has to be of a particular duration, all your responses. So basically, like I said, your TOF, for complete recovery, the ratio should be 0.9. T4 by T1 should be 0.9. So here is your double burst stimulation. As you can see, 750 milliseconds given, three stimuli, two stimulus of each consisting of 3 stimuli, and this is your TOF ratio. This is the control and this is recovery. As you can see, fade is present here, which shouldn't be present, and as the recovery occurs, the fade disappears. Here also, as you can see, fade is present, but this is a tactile thing. This is how it correlates. Okay. So with your, when there is no drug, it is like this. Non-depolarizing blocker, when you give, as you can see, fade of 0.4. Generally, when the ratio is 0.4, reversal can be initiated, not extubation. The reversal agent, the reversal drug can be given. Okay, that's my next class, reversal agent. So reversal agent can be given, and as you can see there is fade, and in your depolarizing block, phase 1 it is constant, but phase 2 a fade occurs. That is again because of your presynaptic mechanisms. So now coming to the types of, for a non-depolarizing blocker, the types of blockade. So an intense neuromuscular blockade, that is there is a period of no response. There is neither your PTC or your TOF or your DDS will show any. I showed you all just now, right? During PTC when I was explaining that in the first intense block, there was no response to either. In your deep block, is characterized by the absence. There is no TOF response, but present of your post-tetanic twitches. That is 1 twitch and 3 twitches in your deep. Your surgical block begins when the first response to TOF stimulation appears. Presence of 1 to 2 responses of TOF indicates sufficient relaxation. So basically your surgical blockade is when the first response to TOF appears. So these are very deep blockades, but adequacy of surgical blockade, 1 response to TOF, and of course your 8 responses to PTC will be present. And 1 to 2 responses, more than 2 basically, is when you can start thinking of recovery. So like I said, recovery, the fourth response, so the ratio of 0.4, the return of the fourth response to TOF heralds recovery phase and presence of spontaneous. But even though the fourth response is present, you can see your fourth response, it does not mean that spontaneous respiration has started. And even if you see, in the sense, it still has to be assessed. A lot of factors have to be taken into consideration, clinically, quantitative, qualitative. So 0.4, the fourth response appearance indicates that the the reversal agent can be initiated, but for a tracheal extubation, that is adequate neuromuscular recovery, this completely excludes residual neuromuscular blockage. So the reversal agent can be initiated when the response, when more than 4 twitches are responses, a return of more than 4 responses have returned. But even if there is spontaneous respiration with 2 responses, it does not indicate it is a sign of recovery. Antagonism, that is with your reversal agent, should not be initiated before at least 2 TOF responses are observed. Ideally 4, not even 2. But it should not be initiated before that at all. Your depolarizing neuromuscular blockade. Now phase 1 block, as I have been saying, TOF, tetanic stimulation, no fade. Phase 2 block, there will be a fade in response to TOF. Now coming to your quantitative, that was all your qualitative. Now coming to your quantitative analysis. The electromyogram, it records the compound muscle action potential. Yeah? So these quantitative analysis basically record a compound muscle action potential. This is done via the recording electrodes, which are placed near the motor point of the muscle, and another one is placed at a slightly different side. So basically the best signal usually is obtained by placing the active electrode is placed over the belly of the muscle, and a reference electrode is placed over the insertion side. So the active electrode is placed over the muscle and the reference is placed over the tendon insertion side. Okay? And the grounding is between these two. So the latency, that is the lag of the action potential, is basically the interval between the stimulus that is given and the muscle response. The amplitude of the compound is proportional to the number of muscle units that respond within a time interval. So basically, what is generated is the muscle action potential, that the amplitude that is shown on the screen is an indication of the number of muscle units, muscle fiber units that are generating an action potential within a time interval. So, like I said, this correlates with your muscle response. So this is how an electromyogram is basically two electrodes, one on the muscle belly and one is usually placed at the tendon insertion site. And after the nerve, after stimulation, activity will be recorded. Your mechanomyography. So basically, your mechanomyography is it is a device isometric. So the adductor pollicis force translation. Basically, it is an adductor pollicis force translation monitor. So it quantifies the force of isometric muscle contraction. The key feature is what is required here is the direction of the thumb movement should be aligned with the transducer. So basically, there will be a transducer. Okay, this is your the transducer is there. So the direction, the thumb direction has to be kept constant. Okay, it cannot, if any movement will alter the reading. So the thumb movement, the direction of the thumb movement should be in line with the pressure transducer. A constant amount of muscle tension, a preload constantly of 200 to 300 grams has to be applied. The transducer and the monitor uh, has to be with adequate monitoring range, and zeroing every time the zeroing of the monitor has to be done before stimulation. So these are certain disadvantages. So it is difficult to set up for stable and accurate measurements because you cannot maintain the muscle, the thumb in that position, right? Preload has to be continuously applied. The transducer orientation and the thumb orientation has to be present, and the maintenance of the muscle temperature is important. All these factors, mechanomyography is basically not very commonly used. What is commonly used is your acceleromyography. Okay? Now, acceleromyography, it is non-isometric. It does not depend on preload and it does not depend on your direction of your muscle. You don't have to maintain the muscle in a particular direction or uh, a particular stance in with respect to the transducer. Okay, so a piezoelectric transducer will determine the state of angular acceleration. It does not depend on the preload and the direction of the thumb. It's based on Newton's second law, force is equal to mass into acceleration. The muscle must be able to move freely in this. You do not have, like in the previous one, the muscle has to be kept in a particular way with regard to the transducer. But here the muscle should be able to move freely. So how this works is the piezoelectric crystal which is in the transducer is distorted by the movement of the crystal that is inlaid in. So the transducer which is applied to the finger uh, that is stimulated by an electric current deforms the crystal within the transducer, which distorts the piezoelectric crystal, which leads to the response. So a piezoelectric crystal is distorted by the movement of the crystal inlaid transducer, which is applied to the finger, and an electric current is produced with a output voltage, which voltage proportional to the deformation of the crystals. The output is proportional to how much the crystal is, the piezoelectric crystal within the transducer is deformed. It is not. It is a non-isometric measurement. Less stringent requirements for immobilization of arm, fingers, and thumb, and there is no preload. Now, in an accelerometry count of 1, so a TOF count of 0.9 corresponds to an accelerometry or count of 1. So that is when there is adequate reversal. Accelerometry of 0.9 or less than that does not indicate adequate muscle reversal. The studies have shown in comparison to TOF, post-tetanic potentiation, that the acceleromyography count has to be 1 to indicate adequate recovery from neuromuscular blockade and no chance, decreased chance of residual paralysis. So this is your acceleromyography. This is most commonly used. This is what is used, not the other two. So here your this is your transducer with your the piezoelectric crystal. Your thumb basically should be able to move freely. These are your electrodes. So once this is stimulated, it basically the contraction here is sensed by the causes a conformational change in the piezoelectric crystal, which is in the transducer. After this stimulation causes a response contraction of the muscle, adductor muscle. It distorts the piezoelectric crystals here, which leads to a response on the screen basically. So these are some of the clinical tests of post-operative neuromuscular recovery. Reliable are sustained head lift for 5 seconds, sustained leg lift, sustained hand grip for 5 seconds, sustained tongue depressor test, a maximum inspiratory pressure of 40 to 50 centimeters of water. Unreliable are sustained eye opening, fusion of the tongue, arm lifting, normal tidal volumes, early tidal, normal vital capacity, and the maximum inspiratory pressure less than 40. But clinical tests alone are not sufficient at all. Okay. So relationship between the clinical and trainer for evoked stimulation is 5-second head lift corresponds to a train of 4.6. Normal grip strength corresponds to about 0.7, and when your masseter muscle recovery corresponds to 0.86. So uh, basically you can initiate neuromuscular reversal when trough ratio is 2 to 4, basically more than 2, between 2 to 4. Reversal agent can be given. Okay. But extubation, that is, extubation should be done only when there is complete muscle recovery. It is initiated when the trough ratio is 0.6 along with all your clinical signs. So basically when your trough is, let's say, less than 2, okay, no reversal. Okay. Your trough is 2 to 4 and your acceleromyography, your trough is basically 2 to 4. Your acceleromyography is showing this. This is with your acceleromyography, your quantitative analysis. Trough is showing 2 to 4. You can give a large dose of reversal agent. When trough is more than 4, 4 to 7 basically, 4 to 7, a moderate dose of reversal agent can be given. This is all with your acceleromyography. And when your trough ratio is more than 7, with a low dose can be given. My next class will deal with these reversal agents, so I'll be covering this again. Okay. Now, only when you are using a peripheral nerve stimulator, that is your qualitative analysis, this is with acceleromyography. If the trough ratio is less than 2, no reversal agent to be given, right? And over here, of course, tracheal extubation is only when the trough ratio is 0.9. This is just what dose of reversal agent can be given and when it can be given. But extubation is when it is trough ratio of 0.9. So trough of less than 2, no reversal agent to be given. A trough ratio of 4 with fade, you can give the TOF ratio of moderate dose can be given of neuromuscular relaxant, and when the TOF ratio is 4 with no fade, okay, a small dose can be given. But again, extubation, these with peripheral nerve stimulator, all these have to be given 15 to 30 minutes before extubation. And once the TOF ratio is 0.9, patient can be extubated. Now, limitations of neuromuscular monitoring. The responses may appear normal despite of persistence of the receptor occupancy by the neuromuscular blocking drug. T4 by T1 ratio is 1 even when 40 to 50% of the receptors are occupied. Patients may have weakness even at TOF ratios at as high as 0.8 to 0.9. Adequate recovery does not guarantee adequate ventilatory function or airway protection. And hypothermia alters the stimulus and hence alters the interpretation of responses. So guys, this was in brief, this was about the neuromuscular monitoring. I just explained to you all just now about how, depending on the TOF, using an acceleromyogram, when to give the reversal agent and when to extubate the patient. So basically, using the clinical features, quantitative analysis like electromyogram and acceleromyogram. Generally, we use acceleromyogram, which determines the TOF, and your qualitative analysis, that is using a peripheral nerve stimulator. You can help to assess the type of stimulation and when adequate recovery reversal can be given and extubation can occur. Now, the types of stimulation that we see are single twitch, train of 4, tetanic stimulation, double burst stimulation, and post-tetanic count stimulation. Your train of 4 stimulation between 2 and anything less than 2, reversal of neuromuscular blockade should not be initiated. TOF ratio of more than 2 and 2 stimuli present, reversal of neuromuscular blockade can be initiated. Ideally, above 4 it is initiated, and extubation is done when the TOF ratio is 0.9. Your double burst stimulation is used for your tactile to see the tactile recovery. Okay, that is the only mode of stimulation where tactile recovery can be assessed, but does not mean if there is no, it does not indicate, if there is no fade, it does not indicate that recovery is complete in either of these methods. The post-tetanic potentiation can be used, it is the only method of stimulation that can be used in intense blocks and deep blocks when there is no response to single twitch stimulation or TOF. So that's it guys for today. My tomorrow's class will be on the reversal agents, on the reversal of neuromuscular blockade. I will compile all this again in brief and tell you. So guys, please subscribe and use my code SASHA and get a 10% discount. Also, you all can access the special classes, right? These are again on our platform, the special classes. Again, these are free classes and they are really good. So guys, please subscribe, use my code like I said, SASHA, and avail your discount. Hurry, don't waste time, start preparing for your NEET PG. Thank you, have a good evening.